Now, should you decide you want to go on and see what a patient on the Wiley protocol looks like and what you might have to do in follow-up, let's go through outcomes. Diagnostic markers of improvement on the Wiley protocol are blood levels, if you're not looking at clinical evidence. Blood levels should reach reference ranges of healthy young reproductive women. If that seems egregious to you, go back to the logical assumption that holds young reproductive women rarely experience heart disease, breast and uterine cancers, osteoporosis, diabetes, Alzheimer's, and what's protecting them is their rhythmic production and reception of sex steroids. When to collect this data? Blood work. Let's draw hormone blood work only 3 months after we start, because in the first month there aren't that many estrogen receptors. Estrogen will make its own receptor. Ultimately on day 12, by the second month, we're making progesterone receptors. By the third month, we should have a full complement of estrogen and progesterone receptors to compare blood values with clinical evidence. Tell the patients very clearly not to draw blood after they've applied hormones to the arm. We do get occult readings up to 6,000 because they're just drawing hormones into the blood sample. So, opposite arms, hours later, something. E2 and P4 levels on day 12 and 21 should be drawn in the morning. It can be after the hormones are applied or before, but it must be consistent. After that, you would draw blood 2 to 4 hours after application or before for optimal results, and you do it every 6 months. In the beginning, you may want to do it every 3 months until the patient is stable. However, every 6 months, because it takes 2 or 3 months to see any alteration you've made in the blood work and in the clinical symptoms. So 6 months makes more sense. The baseline labs are only recommended for patients under 40 for liability purposes. We've looked at slides that say women over 29 are beginning to fall apart if they are not childbearing. If they're childbearing, they can't take these hormones. If they're breastfeeding, they can't take these hormones. So women under 29 are falling apart unless they're living through the 2 other templates of childbearing and nursing that provide them with normalcy. So under 35, you should probably put records in your files showing they needed the hormones for the standard of care. Patients over 35 don't need blood work before beginning the treatment. They're in perimenopause. So the results are unreliable from month to month and won't help you. Reference ranges in serum to shoot for on day 12 are between 350 and 550 picograms and between 1 and 2 nanograms for progesterone. On day 21, the progesterone peak, progesterone in a healthy young woman is between 15 and 21. However, in Wiley protocol patients, you may actually see single digits, 5, 7, because P4 can be bound to red blood cells and albumin, and we're still not sure why. You do get a progesterone effect. You can see it clinically. So it's not affecting its action. However, should you be desperate to see numbers, use blood spot tests, because capillary blood spots will show you there's plenty of progesterone there versus a venous blood spot. Capillary blood spots, however, are inaccurate for estrogen. They just don't work. E2 on day 21 is expected to be between 150 and 250. Again, lab values will differ and ranges may differ because they're different labs. What to do with the data? You should aim for consistency in choice of lab. It would be a dream to have one lab for the whole United States and use that for the Wiley protocol. That would make my studies make much more sense. And perhaps someday, if we can use blood spots and women mail them in, or we can figure out a way to just use one lab, it's possible. Remember that the labs are just a snapshot in time. It's like a particle gun. You're just going to get that proton for a minute because hormones are moving. They're constantly reformatting in shunt physiology, not only to something else, but to a different receptor. Everything's spinning and everything's moving. From the earth to your patient on the earth, to the hormones receiving the environmental cues that are changing hour by hour. So you only use these blood tests as a guide or an excuse to give them more. Patients should be adjusted based on clinical symptoms, not just the numbers. In the Wiley Protocol Clinical Practice Guidelines, a thick book you could have, there will be more articles and discussions on what the clinical signs could mean. Progesterone can be bound to albumin and therefore hard to see in serum. As I said, consider capillary testing if you want to. The half-life of estrogen is 8 to 10 hours, progesterone about twice that. Important follow-up questions for your quick start. When they come back in for your next visit, see their calendar. Ask for it. Ask if you're having a period. How are you applying your hormones? Did you miss any doses? What day did your period start on? How long does your period last? How often do you need to change a tampon or a pad? The normal period should be 5 days with one heavy day, and that's day 2 or 3, where the sides shed simultaneously. If they are having symptoms or haven't ablated the symptoms they came in with, you ask what part of the cycle those symptoms are associated with and look at the calendar. Define when the symptoms occur and check the calendar guide for quick start. We'll show you that graph in a minute. And finally ask, did you change medications or supplements since your last visit? Or labs, someone will always try to sell your patient supplements. Rule number 1 for the Wiley protocol. Always alter the estrogen first. Don't try to alter 2 hormones at once. Never alter the estrogen more than 2 lines per dose, that's BID, daily in one cycle. The receptors will become deranged and fluctuate. Do not adjust the progesterone from the basic. Don't take it down, don't take it up until at least month 3. If your patient is uncomfortable during the luteal phase, depending on the discomfort, and we have answers for that, you can spread out the dose, you can use cabbage leaves and Tylenol for tender breasts. There are many things in the doctor's clinical practice guidelines to help you help your patient adjust to having progesterone for the first time in decades, or if she's never been pregnant, maybe the first time at all in any great way. The progesterone is essential to prevent cancer, to have bone structure, to avoid MS. We need the progesterone, so we need to get it in. Why adjust the estradiol? First, because estradiol creates the receptors for the rest of the cycle. Estradiol, progesterone, and testosterone. Estradiol makes progesterone receptors and activates that P4 reception. P4 controls estradiol at its receptor by setting up activity for the following cycle. So if you don't give them the progesterone, if you give them too little progesterone, estrogen receptors will not repopulate on the next day one. So the estrogen you give them the next month, they won't feel. And they'll say it's not working and demand more because the reception has been diminished by the lack of progesterone previously. Everything rhythmically happens before it happens in the cycle. So, for example, to make progesterone work, estrogen has to have a peak. To make estrogen work, progesterone has to have a peak. And then we just keep rolling. We keep cycling. Thus, always adjust E2 first, no more than 2 lines up or down in a cycle, and never go past E4 on one dose. If you need more, can add it in the middle of the day because you will turn off the receptors. Any intervention you make requires the passing of a couple cycles to see its effect because you're changing receptors. It can take 3 to 9 months to absolutely make a patient feel young again. It takes a while to reestablish nerves, bones, brains, hearts, sleep. Most importantly, sleep. The basic rules for adjusting Wiley protocol dosing is E2. Most symptoms, once you've started the protocol, that are not, we have a woman, she comes in with symptoms. We give her the protocol. The idea is they go away. But if a symptom she didn't have pops up, or those symptoms aren't going away, you can assume they're caused by fluctuation of estradiol receptors. If you spread out the dose to 3-4 times a day, so, an example, the dose is 6 lines morning and night, 6 milligrams. 1 tiny line is a milligram. 6 lines morning and night. You would add that up to get 12 and tell the patient to take 3 lines in the morning, 3 lines at lunch, 3 lines in the afternoon, and 3 lines at night. That would be QID for the same amount. Or you can tell them to take 4, 4, and 4. This slows receptor fluctuation. If you can do that for 72 hours, things often normalize. And you never have to do it again. But communicating with the receptors, talking to the receptors, is the key to making these hormones work. Building P4 receptors can require more estrogen. Only increase the estrogen by 2 lines per cycle, or you can overwhelm the new receptors you're making. So, if you're getting no progesterone response, or an early period, or tender breasts, or we'll go through this, raise the estrogen by 2 lines, morning and night, across the whole cycle. In the beginning, my pharmacies reported to me that 70% of women needed E2 plus 2 more lines. That was the average dose that made everyone feel pretty much better. But erring on the side of less is more, we started the Wiley protocol with the basic dose. I will tell you most of your patients will need at least 2 lines more. Don't be afraid of estrogen. ever. Estrogen doesn't cause cancer. It controls cancer. It is dose dependent. Low-level estrogen proliferates. High estrogen causes G1 arrest and allows progesterone to kill cancer cells within 72 hours. High levels of estrogen stop growth and proliferation. Some possible side effects of the treatment, as we just discussed, may come from fluctuating receptor changes in the follicular phase. Hot flashes or night sweats, they didn't have. Changes in sleep patterns or migraine, they didn't have. If they feel speedy, it is because estrogen, E2, and its receptor creates a dopamine receptor. So they're speeding, but that will diminish within 3 months. High creativity or mood changes is the same. It's like being manic. You have more energy and you clean the whole house, or you finish your project. But it'll diminish and normalize in 3 months. Breast pain or tenderness comes from progesterone creating apoptosis in the ducts, and edema, or the immune system, coming in to clear away the debris. Just the way it does before a normal period in young women or the early part of pregnancy. Some Tylenol makes it go away. For your more natural patients, warm cabbage leaves will make it go away. The reality is, higher estrogen makes it go away. You can raise their dose 1 line morning and night and see if that helps. Diarrhea only occurs because gut motility is changed by estrogen. Diarrhea means, again, you need more estrogen, +1, +2. Acid reflux, not usually, but in women who have had gallbladder problems, you relax the esophageal sphincter and you can get acid reflux or heartburn that is not mechanical. And then, of course, we raise the estrogen. Incontinence is definitely receptor fluctuation or too little estrogen. Anxiety, different than depression. Anxiety, again, spread out the dose of estrogen. Tinnitus, more estrogen, spread it out. TSH-driven palpitations means you don't have a big enough curve to shut off TSH. TSH exists in inverse proportion with estrogen, just like FSH or LH. So you need that curve to turn it off. To quick start your understanding of the dose adjustments I just elucidated, we made a cheat sheet. This is the cheat sheet. The Wiley Protocol Clinical Practice Guidelines Quick Start. If you will look closely, you can see there are words written along the curves. No matter what the symptom, and I have taken 20 symptoms and grouped them into their ultimate mechanism of action, whether they are a seizure response like a hot flash or a migraine or tinnitus or incontinence, or whether they are lack of hormone, which would mean shutting it off, or whether they are too much blocked estrogen in the progesterone phase. I have grouped them into mechanism of action. You can look at this chart, and if a woman tells you on the phone or in person what's wrong with her, your first question is, what day did it occur on of your cycle? She should be able to look at her calendar or her notes and tell you. You look at this little chart, and if it happened between day 6 and 12, just spread out the dose. QID or TID, whatever they're taking, just spread out the dose. Now, that's only if you've raised the dose to +2 first. always try +2 for estrogen deprivation. As it says, day 1 to 5, raise the curve. As it says 13 or 14, raise the curve. That would be in the low spots, they just don't have enough estrogen. So by raising the entire curve, you may solve the fluctuating receptors. The receptors can also fluctuate from lack of hormone. They're looking for it. They're listening for it, and it's not there. So raise it to +2, and then find out if they're better in a month. And if they're not better, go to this chart and do what the chart says. This is pretty much infallible. You can memorize these things. You can memorize the rules. I personally would be delighted if you wanted to understand all the mechanisms of action, all the reasons. But if you don't have time and you want your patients to feel better quicker, you can do this. You can start them on the Wiley protocol at a registered pharmacy and use this chart. And you can't possibly hurt them. You can only make them better. The basic rules for progesterone in the Wiley protocol. The receptors only exist because of estrogen. It takes 2 to 4 cycles before you have as many as you're going to get. In the absence of the progesterone receptor, if you don't have enough and you give too much progesterone, it will go down a glucocorticoid pathway right into a cortisol receptor, which can create edema and weight gain. Now, the reason it does that is because cortisol releases estrogen from SHBG. That means progesterone is trying to make a bigger peak of estrogen on its own. If you just put the progesterone peak in there, you won't have the cortisol effects of edema and weight gain and agitation and sleeplessness. Cortisol will also affect the estrogen part of the cycle. If a woman's dog dies, if her husband leaves her, if she loses her job, estrogen will spin out of her faster because of high cortisol and stress. That is endogenous. You will find she comes back and says, I don't feel good. I have low estrogen symptoms. And in fact, she does. You're going to have to spread out the dose, raise it. You're going to have to find a way for her to calm down. She needs to sleep more, try meditation, and I would tell you even Valium or valerian tea. Just get her to calm down. And it'll go back to normal. A normal period, again, should be 5 days, no more, no less. 1 heavy flow on 2 or 3. If the estrogen seems clinically adequate and your blood work looks good, in other words, she's not complaining, but the progesterone activity, that means your period is not normal, is not quite optimum. The period's too short, the period's too light, the period goes on too long. You can increase day 12 estradiol next time by 2 lines at the peak. Day 11 and 12, 2 extra lines, morning and night. That's if you've already raised it, the whole curve, by 2 lines. And that'll set up more progesterone receptors. This maneuver can extend a cycle that's lasting less than 28 days, and it certainly will stop cramping and clotting. Remember, never give progesterone or estrogen alone, only. Never. Never give progesterone every day. 14 days out of 28 is it. Otherwise, you're blocking all the estrogen and you get the birth control pill or continuous combined effect, even with a rhythm. Without estrogen, P4 will only work for 3 months. And it ends up going down the cortisol pathway. This creates water retention, PMS, weight gain, When cortisol is mobilizing blood sugar, even if it's progesterone causing the cortisol response, you're going to get real weight gain that they have to go back and lose, not just water retention. So you can't let the lack of progesterone action go on for months, or you're going to end up with somebody gaining 30 pounds. And the way not to let that go on is, of course, to have the right amount of estrogen. So you have to go back and check the estrogen. Progesterone alone acts just like cortisol. When day 12 is higher than day 21, this occurs not often, but it occurs. It's called backwards syndrome. For example, day 12, you've got an E2 of 160. Day 21, you've got an E2 of 400 and a progesterone of 5. It is not the progesterone causing that, because you've only got a progesterone of 5. But it has to be the progesterone causing that, because you're giving them half as much estrogen as you did on day 12. So the conundrum can be explained in a couple of ways. The backward system, P4 effect on estrogen equilibrium, means you may not need as high a dose of estrogen in the luteal phase of the cycle. This is a possibility because below we see that insulin and SHBG have an inverse curve. So the higher your insulin is, well received, the lower your SHBG is, and the freer your hormones, testosterone and estrogen, are. So with progesterone stepping in at insulin response substrate 1, creating an amplification of insulin, it would normally release the bound estrogen by lowering SHBG. Now, we have some anecdotal examples of that in pregnant women who need type 1s, who need less insulin as the pregnancy goes on. Progesterone goes up. We have an example in women on hormone replacement who need less insulin on the progesterone or the luteal half. Actually, in women who are not on hormone replacement, young, healthy type 1s, they need less insulin during the luteal phase. So logically, this is what's happening. Logically, the progesterone is being received. It's amplifying the insulin. The insulin in inverse proportion is dropping SHBG, and you're getting freer estrogen. So you're seeing more. You can lower this dose of estrogen to accommodate the numbers, or you can ignore it, and you can raise the peak of estrogen, raise the entire estrogen curve next time. So you have a higher than 160 on day 12. Progesterone affects estrogen metabolism in the luteal phase. That's what you need to know. It affects it through insulin and SHBG. The answer is to decrease the dose in the second half by 1 line, or raise the estrogen curve completely next cycle. There is Wiley protocol testosterone replacement in a rhythm. Women under 60 rarely need testosterone replacement because their adrenals are pumping out enough testosterone to complement the theca cells in the ovary, assuming they're having an LH surge. We also see sometimes in ethnic groups who are more androgen driven, they may need testosterone, but you can measure it and decide to use the rhythm we've got. Wait at least 3 months after testing before introducing the T2. If you give T2 any sooner, you'll decrease estrogen reception. If you don't get the estrogen right first, it actually de-amplifies testosterone reception. Increasing the peak of estrogen can amplify internal production of LH and testosterone's reception. Testosterone shares a receptor with the estrogen receptor. When the testosterone's in the receptor they share. Estrogen reception is downregulated by 35%. So if you give testosterone too soon, you're not going to get the full benefit of the estrogen at the peak or otherwise. Whereas estrogen in that receptor upregulates testosterone's response by 35%. So just getting a woman's estrogen right should give her more testosterone response. Now, should she be missing her ovaries or have adrenal problems, of course you can't upregulate it endogenously just with estrogen. And that's what our testosterone protocol looks like. It's in an orange package, and it has an orange syringe, and you can see there's a curve, and you can add 1, 2, or 3 lines. For pets and children, lastly, there is a buzz in the transdermal community that when you're not using patches, when you're actually using a cream or a gel, pets and children are at risk. The best we can do is cover your arms. This says thighs. I don't recommend thighs for application with clothing after you put it on. So the direct skin-to-skin contact with children and animals and others until it's absorbed, about 4 hours, won't give them that contact high. There have been reports of pet exposure without direct contact. Now, when we discuss that with vets, all we've got are pheromones, airborne hormones. Maybe they're licking it off their fur. If it's on your hands, there's that possibility. It's been reported that spayed pets can go into heat or have enlarged nipples or vulvas. They don't really display aggressive behaviors because they're female dogs. This doesn't seem to happen to male dogs. That's a very important point. Most of these were with small animals, but the estrogen won't hurt them either. You've taken it away from them, and they're living without it. They're neutered. This may prolong their life and make them feel better. Now, there's some endnotes here for you to peruse if you would like more. We're putting up a website with 21,000 citations on estrogen, progesterone, testosterone, insulin, cortisol, DHEA. My research over the last 15 years will be searchable online soon. You could have a doctor's manual. You just need to order it on the Wiley Protocol helpline from Nancy Juniper. It is 450 pages of clinical practice guidelines. Much of it we covered here, but not the ancillary material. And there will be a seminar quarterly for doctors to attain CME credits. If you'd like to go to that, go to the website, and we're going to find Nancy Juniper. She fills those seats. Other than that, I hope to meet you someday. This is T.S. Wiley, and I hope this has been helpful so you can understand the premise, the mechanics, and what you should see in your patients should you decide to use the Wiley Protocol. Thanks for joining us.